Well, in this video we're going to carry on our consideration of applied pharmacology by thinking about the idea of half-life. Now you probably remember in our study of pharmacology there's basically two disciplines or two areas of study. There's pharmacodynamics and pharmacokinetics. Now pharmacodynamics is the way that a drug affects the body. The action the drug has on the body is the pharmacodynamic effect. But pharmacokinetics, which we're thinking about in terms of half-life, is the way that the body affects the drug, the way that the body acts on the drug. So pharmacokinetics looks at things like absorption, how the drug gets into the blood in the first place, the distribution of the drug, how it's metabolized and broken down in order to be eliminated from the body. In other words, the fate of the drug. So it's the absorption, the distribution and the fate of the drug. And when we're talking about half-life, we're talking about an aspect of pharmacokinetics when we're talking about this idea of half-life. And T1/2 is the symbol that everyone recognises that means half-life. So when we give a drug, as we've noted, we can give a drug via enteral or parenteral. Routes of administration, if we're giving a drug for systemic administration, and we want that drug to go into the blood, that's the whole point. Drug in plasma. We need to get the drug into the plasma so it can go all around the body in order to have its pharmacodynamic effect. So to get in via enteral or parenteral, the drug gets into the plasma. But what happens to the drug once it's in the plasma? Well, some drugs are going to be excreted via the kidneys. There's going to be a renal elimination, where the drug is incorporated into the urine and excreted from the body via the urine. Other drugs need to be broken down by the liver first. There's a hepatic elimination of the drug. So the drug will go into the liver in the circulation of the blood, whether it's via the hepatic artery or via the hepatic portal vein. And then there'll be hepatic function. The drug will be acted on by the biochemical systems in the liver, and it will then leave the liver as a breakdown product of the drug, which we call a metabolite. The drug will be broken down normally into several metabolites. Very often these metabolites go on to be excreted via the urine. Now if someone's been drinking alcohol, you can often smell it because drugs can sometimes be excreted via the lungs if they're volatile. And other drugs can be excreted via the bile and via the gastrointestinal tract via the digestive system. So there's these various fates of drugs. Now the half-life is important because it's the time course of action of this elimination. It's the time course of action of the elimination. And obviously in any form of clinical practice we need to know how long our drugs are going to take to work, how long they're going to work for, and how long they're going to be around for. And this is what brings us on to this idea of half-life. I've got a graph here, thinking about half-life. Now in half-life, what we're thinking about is what is called first-order kinetics or first-order elimination. First-order elimination kinetics. Now what do we mean by this? Well, what we have along the bottom of the graph here, this is time. Going that way. These are arbitrary units. It would depend entirely on the drug. They could be minutes, they could be hours, they could be days. So 1, 2, 3, 4, 5, 6 time units. And what we have up here is the plasma concentration of the drug. The amount of drug in the plasma. Now, the bioavailability is the proportion of an administered drug that reaches the systemic circulation in unchanged form. So when we give a drug for systemic absorption, the whole point is to get that drug into the blood. That's what we're trying to do, to get it into the blood. Now, how we give a drug is going to influence how quickly that drug goes into the blood. But for this example, we're going to assume we've given the drug intravenously via a bolus injection. So that means the plasma concentrations of the drug will rise very, very quickly. And let's suppose we give 100 milligrams of drug. So that means after a very short time period, after seconds really, we're going to have 100 milligrams of the drug in the plasma. Now, how will the pharmacokinetics of drug elimination work on this drug which is there? And for most drugs, it's going to be eliminated by what we call first order kinetics. What do we mean? Now, this is the key thing. Half-life is the time taken to eliminate half of the given dose of drug. To eliminate half of the given dose of drug. So, let's suppose the half-life for this drug is an hour. And let's suppose this is 1 hour there. So at time 0, or a few seconds after time 0, we've got 100 milligrams of drug in the plasma. The half-life is the time taken to eliminate half of this given dose of drug. So after the first half-life period has elapsed, up and down there, after one half-life time has elapsed, there'll be 50 milligrams of the drug left in the plasma. So one half-life has now elapsed and we have 50 milligrams of drug left after one half-life. Now the half-life is the time taken to eliminate half of the given dose of drug. Now suppose we hadn't given 100 milligrams, suppose we'd just given 50 milligrams straight off here. In that case, if we'd just given 50 milligrams, then 50 milligrams of drug there in the blood, half of that would be eliminated in one half-life period. So here's the next half-life period here. It's the next half-life period. So 100 there, 50 milligrams of drug left there. That means after another half-life has gone, there's going to be 25 milligrams of drug left there. So the graph is going to be like this. So interestingly, what this means is in the first half-life period, the body was able to eliminate 50 milligrams of drug. In the second half-life period, it only eliminated 25 milligrams of drug. So 50 milligrams were eliminated in the first half-life period, 25 milligrams eliminated in the second half-life period. Because with first order elimination kinetics, when we're thinking about half-life, the proportion of drug eliminated is proportional to the concentration. So when the concentration of the drug is higher, more will be eliminated. This is first order elimination kinetics. Now let's think about another half-life period. After 3 hours in this case, or 3 half-life periods. So there we have the third period. Now, suppose we've only just given 25 milligrams of drug there. That means we're only going to eliminate in one half-life period half of the drug we now have, which is 25 milligrams. So we're only going to eliminate half of 25 milligrams. So that's 12.5. So that's going to go down to 12.5. So that means in the third half-life period, we're eliminating 12.5 milligrams of drug. So, interesting. First half-life period, we eliminated 50 milligrams of drug. Second half-life period, we eliminated 25 milligrams of drug. Third half-life period, we eliminated 12.5 milligrams of drug, because the rate of elimination is related to the concentration. This is the nature of half-life. Let's think about another half-life period. Now can you see it's as if we've just given 12.5 milligrams of drug. So in the next half-life period, we're going to eliminate half of 12.5, which is 6.25. Is it? Yeah, 6.25. 6.25. That's going to go down to 6.25. So it's still one half-life period, but now we've only eliminated 6.25. Then in the next half-life period, I think you're probably getting the idea now. Next half-life period, we're going to eliminate half of 6.25, which is 3.125. Is it? Yeah, that's right, 3.125. So we're going to be half there. So that's going to take us down to 3.125. And I think you get the idea after 6 hours it will be 1.5 plus half of 1.25, whatever that is. So can you see the amount of drug is going to go progressively down? In theory there'll always be a tiny bit left, but that's the idea of half-life anyway. A half-life. So half-life is the time from peak plasma concentration until half of the drug is eliminated, and there's going to be repeated half-lives as the drug is cleared. There's going to be clearance. And what we normally say is that the drug is eliminated after 5 half-lives. So by the time we get to here, we can say that basically the drug has been eliminated. Actually, about 95% of the drug will be eliminated after about 4.5 hours. So after 5 half-lives, essentially there's going to be none left. Now, this is interesting because drugs, of course, have a therapeutic range. So let's assume the therapeutic range of this drug is from about 100 milligrams to, let's say it's 30 milligrams. So this particular drug has a therapeutic range from just over 100 milligrams to 30 milligrams. That is the therapeutic range of this drug. The therapeutic range. So when we've got 100 milligrams of drug, the drug's going to be working because it's in the therapeutic range. But what this means is after, in this case, less than 2 half-lives, it's going to fall below the therapeutic range. And here the drug is not in sufficient plasma concentrations to have the therapeutic efficacy that we would like. So what this means is, if this drug's got a relatively short half-life, we're going to have to give another dose to get this back up. We need to give another dose to get it back up. So we give another dose there, that'll get it back up. And then, of course, that's going to start to be eliminated again. Then we have to give another one. And we have to get the idea. We have to give another one to keep it in the therapeutic range. That'll start to be eliminated. So this is why we have to give repeat doses of drugs to keep them within the therapeutic range of efficacy for pharmacodynamic function. This is why if we give an infusion of a drug, we can set the infusion rate to balance the elimination rate. So we can have a drug which is kept at a constant level if we carry on infusing it. So here we've set the infusion rate to match the elimination rate, and that will give us a constant therapeutic plasma concentration. You could get a similar effect with transdermal administration, for example. So half-life has got quite a few of these practical applications. Now, if we're giving a drug orally, actually the steady state of the drug might not be realised for some time. In fact, if we're giving a drug orally via oral doses, the steady state is only going to be reached after 5 or 6 half-lives. In fact, it's going to take 3.3 half-lives to get to 90% of our final concentration. So remember, this is our therapeutic range here and here. So if we give a drug orally, we'll give it orally, but some's going to be eliminated. Give some more, some's going to be eliminated. Give another dose. So can you see it's going to take several half-lives, potentially, for us to get into the therapeutic range. And once we're there, we can give the drug to keep it in the therapeutic range. So it's important to realise that a drug is only eliminated, or a drug will be eliminated after about 5 half-lives have elapsed. But it's also important to notice that steady state plasma concentrations within the therapeutic range will only be reached after 5 or 6 half-lives, or certainly about 3.3 half-lives to reach 90% of where we'd like it to be. So that means the onset of the drug can be slow. This is why we sometimes give a loading dose. So a loading dose is a higher initial dose of the drug that we give the first time we give it. So if we give a loading dose, we might give an extra dose, and that's going to put us up there, so we get into the therapeutic range quickly. So with antibiotics, for example, we might give an additional early dose to get us into the therapeutic range quickly, because we don't want to be waiting ages for our drug to work. We want it to work quickly, so we can give a loading dose. All different aspects of these first order elimination kinetics. Now I think maybe to bring this to life a bit, we might give some real life examples. So here's some common drugs. You may well recognise some of these. Now noradrenaline, or norepinephrine, has got a very short half-life, about 2 minutes. So if you give someone an intravenous dose of norepinephrine or noradrenaline, you can see the heart rate go up, but then it will go down fairly quickly after a few minutes because the half-life of the drug is short. It's quickly metabolised and broken down by different biochemical systems in the body. This is why in intensive care type situations, if we want to give noradrenaline for cardiac support or to maintain blood pressure, we give it via infusions. So we can match the dose we give with the excretion, maintaining a constant, or relatively constant, therapeutic plasma concentration. Salbutamol's half-life is about 1.6 hours, so relatively short. Morphine, typically 2 to 3 hours. So we often give repeat doses of morphine if we need it every 4 hours or so, because the half-life is just a few hours, 3 hours. But methadone, when we're getting people to withdraw from morphine, has got a much longer half-life, which is good because hopefully that takes away the cravings for a longer period of time. Gentamicin, common antibiotic, half-life about 2 to 3 hours. Penicillin, perhaps the most commonly used type antibiotic, say 6 to 8 hours. So if we want to keep a fairly constant concentration, can you see we might give that 4 times a day? So we can keep it nicely up here on this green line in the therapeutic range by giving repeated doses. So give a dose there, concentration will start to drop because it will be eliminated, so we give some more to keep it topped up, to keep it within this nice therapeutic range. Diazepam is quite a long-acting benzodiazepine, it's about 24 hours. Other drugs like Ativan, what's that, lorazepam, that's got a very short half-life. That's actually what makes it a fairly dangerous benzodiazepine, because the drugs with a shorter half-life tend to work much more quickly, and people become dependent on the effects much more quickly. Fluoxetine, very commonly used antidepressants, Prozac, 6 days. So that's why it often takes a week or two for fluoxetine to start working. It's more complicated than that, but people can feel worse before they feel better. But we notice it's got a long half-life. So if you miss a dose, it doesn't matter too much. You can just start taking it the next day, or even take the dose later, and if it's a 20 milligram dose anyway, that would be okay. You see we're getting into specific pharmacology now, which best to avoid. These are the principles. So warfarin is about 4 days. Warfarin, of course, is Coumadin. So that just gives you a few ideas of different half-lives of things to think about. Now there is another type of kinetics called zero-order kinetics. So zero-order kinetics. And again, if you think about a basic graph here, as we had before with time and concentration in the plasma there. Now with zero-order kinetics, it's a different situation because the elimination of the drug is not related to the plasma concentration. So much drug will be eliminated per unit of time. So a very good example, of course, is alcohol. In alcohol, approximately one unit of alcohol equals 10 mils of pure ethanol. That would be 1 unit of alcohol. So if I drink, suppose I drink 10 units of alcohol, then after 1 hour, after 1 hour, I'm going to be down to, that's 5, 6, 7, 8, 9. After 1 hour, I'm only going, so I start off with 10 units of alcohol, which I've drank. Oh no, it would take time to build up to that, but I suppose we're cutting in 10 units. And I go home after drinking 10 units. Then after 1 hour, I'm only going to eliminate 1 unit, so there's going to be 9 left. Then after another hour, I'm only going to eliminate another unit, so there's going to be 8 left. And then 7 left. So what happens is, we go from 10, 9, 8, 7, 6, 5, 4, 3, 2, down to 1, 0. What's happening here is the elimination is linear. If I draw my graph better, it will be a straight line, linear elimination. Because in first order kinetics, in zero order kinetics, which we're looking at now, this is zero order kinetics. In zero order kinetics, the elimination of the drug is not dependent on the concentration, but only so much is broken down per period of time. This is called saturation genetics. This is a common problem on A&E. If someone drinks 20 units of alcohol and they go home at 10 o'clock at night with 20 units of alcohol in their blood, and they get up for work at 7 o'clock the next morning, then that's only 9 hours later. So if they've drank 20 units of alcohol, 9 hours later, they're still going to have 11 units of alcohol left in their blood, which is enough to make them have road traffic accidents on their way to work. So remember, most drugs are first order. Most drugs are first order kinetics like this, where the excretion is proportional to the concentration. But there are a few things that are eliminated by zero order kinetics. And in that case, only so much is eliminated per hour because the body is only capable of breaking down so much per hour. So in the liver, for example, you only have so many hepatocytes, so many liver cells with the dehydrogenasing enzymes. And once all those enzymes and cells are busy, the rest of the alcohol just has to wait. So drugs which are eliminated by zero order: alcohol, phenytoin, warfarin, which is Coumadin, heparin, paracetamol, and aspirin if it's taken in overdose. Although if aspirin's taken in normal doses, the half-life is relatively short, about 3 or 4 hours if it's taken in normal doses. But if a lot is taken, the body can't eliminate it all at once. So zero order kinetics, the body breaks down a particular amount of drug per unit time. First order kinetics, the drug eliminates half of the given dose of drug. in a particular period of time in the half-life. So with this first order kinetics, the rate of elimination increases as the concentration increases.